In this presentation, I would like to discuss with you the rare brain malformations that can occur in the third trimester of pregnancy after a normal 20-week anomaly scan. The first case is a lady who was pregnant for the first time. She was 32 weeks and then she was referred to us because of hypertension. We did a biometry scan and saw that there was a large head circumference. There was a ventriculomegaly of 14 to 15 millimeters of the posterior horn. We couldn't find a cavum septum. There's a bit of enlargement of the third ventricle, but no cavum septum over here, and a shift of the brain tissue over the midline. Here you can see this in a coronal view, where you can see both eye sockets over here. This is the nasal septum, so this is the midline. And here we can see the interhemispheric fissure of the brain, which is shifted over the midline. Furthermore, it was difficult to see gyration. There was a small amount of subarachnoid fluid. And then we performed an antenatal MRI, which was really difficult because of a lot of fetal movements. In these images, you can see that one of the brain halves is bigger than the other one. The color of the brain tissue is different. You can see that this part of the brain, the gyration pattern, is really abnormal. There is less gyration than you can see on the other side. And here again you can see the shift of the midline in the coronal plane. Then we thought, what's going on? Is this an infection? Is this thrombosis? Is this a tumor? Or is this a migration disorder? And after 2 weeks we had to terminate pregnancy due to a really severe preeclampsia of the mother. And we performed a cesarean where a baby girl was born, and she was admitted to the ICU because of continuous epileptic seizures. They turned out to be really untreatable. She had 8 different kinds of anti-epileptic drugs, and nothing really helped. There was a consultation with the neonatologist and the children's neurologist with parents on what to do. There could be done a hemispherectomy to control the seizures, but this would of course also have consequences for the outcome, and parents decided not to do this. They didn't want it for their daughter, and they decided to do a redirection of care, and the baby died 4 days after she was born. In the genetic evaluation, this turned out to be a PTEN mutation causing hemimegalencephaly. If we look at hemimegalencephaly, it's a really rare condition. On ultrasound, you can see the asymmetry of the cerebral hemispheres due to overgrowth of one side. There's interhemispheric shifting. You can see an asymmetrical ventriculomegaly. There's abnormal cortical development, especially of the large side of the brain, and there's a large head circumference. It's caused by a migration disorder, often due to genetic malformations, but not always. And in the outcome, you have untreatable seizures, and as said before, you can perform a hemispherectomy for seizure control, but this will turn out to give hemiplegia. And there's often a progressive neurodevelopmental delay. This is the second case, and this is a case of Katia Bilardo, which she asked me to present over here. This lady was pregnant for the 3rd time. She had 2 uneventful pregnancies in her history, with 2 healthy children, and both deliveries were by cesarean section. In this pregnancy, there was a normal 20-week scan, and she was referred at a gestational age of 27 weeks and 5 days because there was suspicion on an encephalocele. On ultrasound, they saw macrocephaly, And there were hardly any normal brain structures recognizable, as you can see over here. There were large cystic parts, but also a large echodense mass, and extracranial, there was also a large mass visible. This mass turned to grow really rapidly on the follow-up scans. There was a fetal MRI performed, and they actually confirmed what was seen on ultrasound. And you can see that the head circumference is really large. There is hardly any brain tissue left anymore, or normal brain tissue. You can see the abnormal echodense mass, and here the cystic structures. But you can also see that there is some of the tissue growing outside the skull. And the axial plane, you can see this also. If you look at the 3D picture of the baby, you can see that the mass is growing outside one of the eye sockets. So this was a large brain tumor, and differential diagnosis was a teratoma, astrocytoma, or craniopharyngioma. Because there was a really poor prognosis, parents opted for late termination of pregnancy, and this was performed at a gestational age of 29 weeks, first as a feticide and then after that a cesarean section. There a little boy was delivered, and you can see that there's really a large amount of tissue growing outside the eye socket, as we saw on the antenatal scan too. Parents did not allow pathological examination. If we look at fetal brain tumors, what can we see on ultrasound? We can see microcephaly, we can see intracranial masses, we can see hydrocephaly, intracranial hemorrhage, and fetal hydrops. This is a study by Isaacs, in which he was able to collect 154 fetal brain tumors, which is quite a challenge because it's really rare. And you can see that from the 155 cases, only 15% survived. And so the survival of fetal brain tumors is really low. What kind of tumors can you see? Well, for the largest part, these are teratomas in 42%. They're mostly inoperable. They involve large areas of the brain, and they have a tendency to grow really rapidly into the orbit, the oropharynx, or the neck, as we could see in our case, and the survival is only 7.8%. The second tumor, which you can see in 25%, is the astrocytoma. This is mostly situated supratentorial. They have a range from benign tumors to malignant tumors, and the overall survival is 21%, but in the benign cases it can be a lot higher. Then the craniopharyngioma in 11%. These are really common in childhood, but are really rare in fetal life. This tumor arises from the roof of the mouth, radius pouch, and have a close relation to the pituitary gland, and the overall survival is 23%. Then the last one that I wanted to discuss is the choroid plexus papilloma in 5.2%. This is a cauliflower-like lesion. It grows into the lateral ventricles and less often in the third and the fourth ventricle. It produces large amounts of cerebrospinal fluid and therefore causes hydrocephaly and macrocephaly. These tumors can be completely resected, and then this often results in cure, but there's a high risk of hemorrhage because these tumors are highly vascular. Overall survival, 38%. So besides what's happening to the fetus, we also have to take into account what happens to the mother, because there can be complications due to a cephalopelvic disproportion. And in our case, as I said earlier, this probably was a teratoma. And then we have the third case. This was a lady who was pregnant for the second time, uneventful previous pregnancy, and she was referred for a mild ventriculomegaly at 20 weeks. So she didn't have a normal 20-week scan, but a mild abnormality. And because the case is so interesting, I decided to discuss it also. On ultrasound, we saw a lateral ventricle with a posterior, well, it was enlarged with a posterior horn of 10.9 over here. And the ventral horn was also big, 6.4 millimeters. There was a normal head circumference, there was a normal anatomy, and a normal development of the brain until now. You had a marginal enlargement of the third ventricle. We offered additional diagnostics. Parents chose for genetic testing, and we had a normal QF-PCR, normal airway, normal WES. We did maternal serology, CMV and toxoplasmosis, and these were also negative. And then we performed a follow-up scan at the gestational age of 29 weeks. And then I'm going to show you the pictures, because what we saw here was in the plane of the head circumference, we could see a ventriculomegaly of 12 millimeters. But if you moved a little bit upwards, you can see that there was more outspoken ventriculomegaly. And also, if you look at the cavum septi pellucidi, it looked like one of the leaflets was missing over here. This was also seen in the coronal view, and so the frontal horns were larger than you should expect. And here you have the cavum septum. And if you moved a little bit more to posterior, then you could see here also that it looked like this septum was missing over here or ruptured. We looked with 3D and we saw a normal corpus callosum and with a bit of a cavum vergae over here. Fetal MRI was offered, but parents declined, and at 39 weeks she delivered spontaneously of a boy of 7 pounds. And this is what we saw on the postnatal MRI. So there was a genesis of the cavum septi pellucidum, or the septum pellucidum, over here. So you had enlarged lateral ventricles. We had a small but a complete corpus callosum over here, a normal pituitary gland, normal gyration, but a hypoplasia of the optic chiasma and the optic nerve over here. So this was a septo-optic dysplasia, or de Morsier syndrome. And you speak of a septo-optic dysplasia if you have 2 of these 3 diagnostic features. And so the first is an absent or hypoplasia of the septal leaflets, so fusion of your frontal horns. The second one is the hypoplasia of your pituitary gland. And the third one is hypoplasia of the chiasma opticum, or the optic nerves. And 30% of the children with a septo-optic dysplasia have all of these 3 features. The outcome of an isolated septo-optic dysplasia can vary. There can be visual impairment, there can be an endocrine dysfunction and a delay in growth, and a rather large part of the children have mental retardation. And of course, when there are associated malformations inside the central nervous system or outside, then the outcome is worse. The differential diagnosis is, of course, also an isolated absence of the septal leaflets of the septum pellucidum, and this normally has a good prognosis. Although 25% of the children with an agenesis of the septum pellucidum has septal optic dysplasia. You also have to think about holoprosencephaly, and especially the lower holoprosencephaly, agenesis and dysgenesis of the corpus callosum, or an hydrocephalus. Could we prenatally image the optic tract and the pituitary gland? Well, we can perform a prenatal MRI at which we can see the optic chiasma, but the further we do this MRI during gestational age, the better the images are. So preferably do it after gestational age of 26 weeks. But for a lot of countries, that is a little bit too late, because parents can only terminate pregnancy until 24 weeks in the Netherlands, for instance, and in some countries even at a lower gestational age at which termination of pregnancy is allowed. So that makes it difficult. There are also studies which show that we can look at the optic chiasma with 3D. That is a study of Bolt. There are also reference charts for normal measurements of the optic nerve, but this is really a challenge. And then we can look at maternal estriol levels in blood, and if it's low, that this should be associated with a septal optic dysplasia. But this is challenging because normal maternal estriol levels cannot rule out a septal optic dysplasia. And as I said, often termination of pregnancy is legal until 24 weeks or even less. And so before that, you have to have all your imaging. An MRI below a gestational age of 24 weeks to assess the optic tract and the pituitary region is really a challenge. The 3D imaging of the optic tract is also difficult. And if there are normal measurements prenatally, they do not rule out the septal optic dysplasia because there's a potential of progressive atrophy postnatally. So the final diagnosis can only be confirmed postnatally. So in this presentation, I hope I have shown some rare cases, and I thank you for your attention.